Good day, dear great surgeons. Miss you all a lot, and today we're gonna discuss together a general blood chapter like the pathology. The pathology is very important because it's overlapping with every chapter. It's like a general revision for the whole MRCS scope, and that's why in our interactive guide we recommend studying pathology after studying the main chapter's scope. So when you are starting reading the pathology chapter, you can find it as a general revision. So let's have this chapter general revision together, and together we can with the grace of God. Let's start with our very first question. We are here talking about the wound healing. What is incorrect? And take care from this trap. What is incorrect? So are the Afro-Caribbean skin archeloid formers? Yes, they are. How about extensive third-degree burn and wound contracture? Yes, it can have. How about poor healing at the site of previous radiotherapy? Yes, it does occur. And zinc deficiency and delayed healing are relevant. Yes, but the chemotherapy and wound healing is not relevant to the wound healing at all. That's why we have to do an applied relationship. In plastic surgery, when we do mastectomy for any tumor and you are planning this patient to have a radiotherapy, would you recommend giving her a silicone implant? No, it will extrude by radiation. But if she is going through chemotherapy, you can go with implant. But if you are going to do radiotherapy, there will be dehiscence with radiotherapy, not the chemotherapy. As well as during the COVID-19, we faced a very tragic era where there was a deficiency in zinc and vitamin C, which are important for us as plastic surgeons in our regimen because they improve the wound healing. So we don't like a patient to go through zinc deficiency. Thanks for COVID, they ate the vitamin C and zinc tablets. From wherever you are, I'm sure you have faced this. And regarding the third degree burn, would it hurt? Would it be painful or not? Thank you, Dr. Adi.
Not, yeah.
Yes, it will not be painful at all. How about the first and second degree? Will they bear pain or not?
Pain.
That's great. There will be pain. How about ischemia? Ischemia doesn't come with pain, right or wrong?
Please repeat the question.
Again, if you have an ischemic limb, will there be a pain or not?
Pain. Severe pain.
Severe pain. So if we have an ischemic limb or ischemia, there will be a severe pain. There are 6 P of ischemia. Who can enumerate the 6 P for ischemia?
Yes, pallor,
Pain, pallor,
pallor, paresthesia,
paresthesia, paralysis, pulselessness, and poikilothermia. What is poikilothermia? It's a hypothermia. Thank you. You are such a great surgeon. Let's have another trick. How would you manage a keloid? Which surgical excision is the choice for keloid?
and implicit corticosteroids.
Intralesional corticosteroid and compression garment, as well as silicone sheeting. The treble assessment for the treble therapy for keloid is very important. Again, for keloid, surgery is not recommended at all. and it's very common in the darker skin than the whiter, lighter skin regarding statistics. And what is the difference between keloid and hypertrophic scarring clinically?
المارجن.
The margin. So, which of them will be exceeding the margin and will not respect the margin?
keloid.
The keloid will not respect the margin. That's great. But the hypertrophic scar can be managed surgically and will give a great result because it's respectful. It respects the margin. It has rules. But the keloid former has no rules. So take care to do piercing in the nose or the ear in a keloid former body. It will create a keloid. Have anyone didn't see a keloid before? If anyone didn't see a keloid, I will share with you a keloid. Just in case you didn't see a keloid, this is a keloid. Very hard to treat, by the way. And you are such amazing surgeons. You answered a very difficult question. A 5-year-old baby found to have a mecal diverticulum and appendectomy, and it looks not inflamed. What type of epithelium is most likely to be found in this diverticulum? You all answered correct. Yes, it's ileal mucosa. And most asymptomatic mecal diverticulum will be lined with ileal mucosa. But those which present with bleeding will be more likely to have what type of mucosa?
Gastric mucosa.
Thank you, Dr. Naeem. You are such a great surgeon. So if we have bleeding, it's a gastric. If there is no bleeding, most probably it will be ileal mucosa. And by the way, the mecal diverticulum has a rule called the rule of 2.
2.
2% of the 2 inch long, 2 feet from the ileocecal junction. Again, the rule of 2, 2% of population, 2-inch long, 2 feet from the ileocecal valve. And it can be associated with enterocytoma, umbilical sinuses, and imperioileal fistula. How about if we have urine coming out of the umbilicus? Will it be a mecal diverticulum or a patent vitello-intestinal duct? It's a urachus. Yes, it's arcus. Urachus or arcus. Whatever you tell it, it will be understood from the examiner in the OSCE. In the exam, in the first part, it will be just MCQ. Can we have pancreatic cell in the mecal diverticulum?
Yes.
So yes. How about it?
Yes.
The mecal diverticulum must be removed in all circumstances. Once you find a mecal diverticulum, would you remove it?
No.
There is a rule in medicine, you have to keep it in mind, especially in answering an MCQ exam. It's never all. It's never an absolute. If he asked you in absolute, so it's wrong. In all circumstances will be removed the mecal diverticulum? No. It will be removed if narrow neck or symptomatic. It will be either a formal excision with anastomosis or a wedge excision. So when would you remove it? If it's asymptomatic, it's symptomatic, not asymptomatic. Symptomatic, it's showing symptoms like pain, bleeding, or if it's a narrow neck. Clear? We thought
Clear.
of it in the very last session. So let's have another happy question. We have a 30-year-old man suspected of having appendicitis, and operation, it's inflamed mecal diverticulum found. What is the responsible vessel for the mecal diverticulum?
Peace with the line.
What is the blood supply for the mecal diverticulum? Yes, it's the vitelline artery. The vitelline artery supplies the mecal diverticulum, and it's derived from the iliac arcade. How about the appendix? What is the artery supplying the appendix? Thank you, Dr. Aisha. It is the appendicular artery. And the appendicular artery is a branch from? Thank you, Dr. Langdon and Dr. Sahar. Yes, it is the ileocaudate. And the ileocaudate is a branch from?
Superior mesenteric artery.
Superior mesenteric
Right
artery, and the level at the aorta, the vertebral level of the superior mesenteric artery from the aorta will be at?
L4.
L1. L1. How about the inferior mesenteric? What is the level of the inferior mesenteric? So the superior mesenteric will be L1, the inferior mesenteric will be L3, and the ileocaudate is the branch for the appendicular artery, and it's a branch from superior mesenteric. So superior mesenteric is giving the ascending and part of the transverse, while the inferior mesenteric is giving the left descending column. Am I correct?
Correct.
Thank you, Dr. Sahar. So in this question, you have to learn something. He will not ask you always about the decision. It might be a long scenario asking you about a direct question regarding a pure anatomy. Okay, let's have another tricky question. We have the same 30-year-old man, but presenting with abdominal distension, and laparotomy is performed, and at the operation is filled with large amount of gelatinous fluid. What is the most likely diagnosis? If you saw it once, you will not forget it. Again, I can't hear you. The jelly belly. Pseudomyxoma peritoneae. Yes, it will be the jelly belly. If you don't know what is the jelly belly, here it is. If you see it once, you will not forget it at all. You will find true jelly. I'll try to find you a pure photo for it. And by the way, it's a very hard case. And any of you does know how it would be treated?
Peritoniectomy.
Okay. Would you like to give it a chemotherapy intraperitoneal?
Yes.
What is the machine? Do you know anything called Hybec? Do you know the Hybec? Yes, Dr. Naz, the Hybec. How do you know the Hybec? I've been studying lately. A simple, direct question. You know the jelly belly, pseudomyxoma peritonei, but it will be asking you about the management in the pseudomyxoma peritonei because it's a very rare condition. Yes, it's a hyperthermic intraperitoneal chemotherapy. Very important to know. So the pseudomyxoma peritonei, the curative treatment will be peritonectomy, like you all said, and it's called the sugar baker procedure. And heated intraperitoneal chemotherapy, the short will be HIBEC, and it's an international short synonym. So you have to be familiar with the word HIBEC, hyperthermic intraperitoneal chemotherapy, the jelly belly. Never forget it. Okay? Okay. So you answered the whole question. Right. Let's have a true pathology question that will test your general knowledge regarding the pathology, the core of the pathology, about the gas gangrene. And again, in this question, take care, he is asking you, what is untrue? There is necrosis with putrefaction. In gas gangrene, yes, that's correct. The causative pathogen may be detected on normal perineal skin, yes. A hyperbaric oxygen may be beneficial in gas gangrene, yes. Clostridium perfringens is a recognized cause, yes. But the treatment will be only a low dose of penicillin, of course not. It's a gas forming organism. So a rapid surgery and high dose of antibiotic are the indicated treatment for the gas gangrene. It's a life-saving. And there will be crevitis, blackish discoloration with blistering and hemorrhagic body. And the crevitis is like never. It's unforgettable sensation. Have any of you faced a gas gangrene before? Thank God, it's a nightmare. I hope you all don't face the gas gangrene. And if we mention the gas gangrene, we have to mention the necrotizing fasciitis because it's an advancing soft tissue infection associated with fascial necrosis. It's uncommon, but can be fatal as well. And it's very common in a patient who is immunocompromised. And it's a polymicrobial, by the way, and can lead to a gas-forming organism, gas gangrene as well. So, what is the difference between the dry gangrene and the wet gangrene and the gas gangrene? There are a lot of difference between them. I like this word, the demarcation line. Yes, the dry gangrene has a demarcation line, but the wet gangrene has no demarcation line. Wet gangrene is a bad sign, requires surgical intervention, while the dry gangrene doesn't require urgent surgical intervention. It's like mummified. Let's have, I will share a photo and you tell me which is which. Which of them is the dry and which of them is the wet from the photo? I'll be so happy if you take a screenshot or just do a marking on the photo. You are a surgeon. You have to understand what you are telling, not just memorization. Okay. No one is willing to take any screenshots. Such impressive. Thank you, thank you. Thank you, Dr. Aditi. Thank you, Dr. Sakar. You are such a great surgeon. You'll be such a unique surgeon. And here we have another picture. The latest picture, this picture is showing to you a necrotizing fasciitis complicated with gas gangrene. Let's have another question. Ready? This question, I want you to answer fast. We have talked about it a lot. So a 52-year-old lady referred to you with symptoms of nipple discharge. That discharge is thick and green. So he is talking about what? What is this? It's mammary duct ectasia. Exactly, Dr. Aisha. Thank you. You are such a rocket surgeon. So he is asking you about what is untrue. So does the majority of the patient are smokers? Yes, they are all smokers. It's not associated with increase in breast cancer. Yes, it's not a precancerous. May result in development of mammary duct fistula. Yes, it might cause a fistula. Might require a total duct excision like a Hatfield operation. And again, he is telling you in this question that it's a major duct, total duct excision, because we told you that the microductectomy is for the papilloma. And if it fails to resolve, it will require total duct excision. Yes, it will require a Hatfield operation. But does it produce blood-stained nipple discharge? No, it's not blood-stained. The blood-stained would be papilloma, just like Dr. Langdon told us. Yes, thank you, Dr. Langdon. Thank you. You are such mind reader, telepathic surgeon. So it's not common to have ductectasia with blood, and even the cancer breast is not common to have blood. The most common cause for bleeding per nipple is papilloma. However, You will tell the diagnosis without investigation. How would you investigate a breast coming to you with bleeding per nipple? How would you investigate for it? How would you manage it? Any breast, any thyroid will be triple assessment. History and examination, investigation, and biopsy. The investigation will be, yes, Dr. Isha, triple assessment. So the investigation will be in breast, either mammography or ultrasound. Ultrasound, if she is younger than 30, older than 30, we will do mammogram. Unless she has already a history, she will be doing an MRI. The same goes for the thyroid. And of course, you will do a biopsy. In the breast, would you like to do fine needle biopsy or core biopsy if there is a mass? Core biopsy, exactly. How about the fine needle in the thyroid? Is it preferable and can differentiate between what and can differentiate between what in the thyroid? Fine needle in the thyroid. Thank you, Dr. Sarkar. So the fine needle is great in thyroid and it's a part of the triple assessment of the thyroid, but it's not good for the follicular. It can differentiate between the follicular cancer and adenoma. So happy with you all. You are such a great surgeon. So if you have a patient came to you with a trauma in her breast and found a mass, what did this mass most probably to be? Fat necrosis. How would you manage a fat necrosis? Thank you, Dr. Bartholomew. You will have to exclude the cancer. If it's a pure fat necrosis by history, but we have impressed the treble assessment, so I have to exclude the cancer and not be satisfied only with the history and examination. Thank you. I hope I'm not repeating unknown ideas. I want to stress on the idea of how to think, because in your upcoming exams, the probability of repetition of the question will be low, but it will be more probably to have the idea and the concept more than repetition of the same question. So I want you to understand how to answer, how to grasp the idea. Hope it's clear. And if you found it just a repetition, you can tell me. I'm all open-minded regarding this. So a pregnant woman suddenly developed bilateral leg swelling. Her mother and aunt were troubled by the same problem. What is the most likely? What is the most likely? So it's an antiphospholipid syndrome. It will have three antibodies: the lupus anticoagulant, anticardiolipin, and anti-B glycoprotein. I want to ask you about the antiphospholipid syndrome. Regarding this antiphospholipid syndrome, this woman will have recurrent abortions. She might come with a Miller rash. Tell me a cardiac symptom, a cardiac disease that can come to you with a Miller rash. Do you know the malar rash, like the butterfly sign on the cheeks? So this is not a pretty lady. She is lupus. Take care. If you are going to marry and found a reddish cheeks, she is not a hot chick. She is a lupus, dearest brother. Take care. And by the way, being a lupus with a red cheeks, she will have many to think of, like a kidney failure, like you will have your fetus recurrent abortions. She will have photosensitivity, alopecia, and hair will be falling. In her heart, she will be chest pain and heart murmurs, and her joints will be swollen and arthritis. So if you got deceived by those red cheeks, you will get a lupus patient. Take care. That's the difference between a doctor is getting married and a non-physician and non-doctor who is getting married. You understand what you are taking in your life as a wife. So tell me again, I'm waiting for the answer. What cardiac disease can get a malar rash?
Yes.
Again, mitral stenosis. Yes, mitral stenosis. That's what I'm thinking of and I'm searching for, and it can come in your exam. Very common question to be asked in the exam. So thank you. So is it common to have a lupus patient with a kidney failure? So take care. It's a very common question to be asked. So let's get out of this marriage situation and have another happy question for you. We have a 73-year-old man undergoes emergency amputation for severe lower limb sepsis and gangrene. And post-operatively, he developed DIC, disseminated intravascular coagulation. This is coming. Which of the following clot factors will be most rapidly consumed in the DIC? This is coming.
Factor 8.
So the DIC will tend to consume factor 5, 8, and platelets. Factor 5, 8, and platelets. That's why DIC is death is coming. Disseminated intravascular coagulopathy. It's a very serious complication. It will be a simultaneous coagulation and hemorrhage caused by initial formation of thrombi, which will consume the clotting factor, and you will find the patient, unfortunately, bleed from every orifice. This is DIC. If you found the patient suddenly bleeding per anus, bleeding per mouth, bleeding per nose, bleeding from every orifice in his body, and bleeding from every puncture you do, he didn't develop hemophilia at age of 73. He is going to do and to be in DIC. And it can be caused by infection, malignancy, even trauma, major surgery and trauma, and liver disease, obstetric complication. You must keep DIC in mind. Clear?
Clear.
It's a nightmare for the surgery and must be in your mind. Again, look at the question and memorize it. May God save you from this patient in your practice. But in myself, in my practice, I have seen at least 5 cases going through DIC, and it's a nightmare. It's hardly to be reversed. And the only treatment is to do supportive management for the underlying causes. So again, for the DIC, disseminated intravascular coagulation, The clinic will be bruising, ischemia, and organ failure, as well as bleeding by every orifice. And you have to do blood test. All increased platelet decrease. Yes, there will be decreased fibrinogen, but increased fibrinogen degradation product. The DIC take care that there will be increased fibrinogen degradation product, but the fibrinogen will be decreased. Clear?
Clear.
Very common to be asked in the exam. The DIC, in the disseminated intravascular coagulopathy, the fibrinogen degradation product will increase or decrease?
Increase.
That's great. How about the fibrinogen itself? Will it decrease or increase?
Increase.
The fibrinogen in itself will be decreased, but the fibrinogen degradation product will be increased.
Increase.
If you don't want to memorize it, we said that the DIC, we have hypercoagulability state. It consumed all the coagulative factors. So the fibrinogen is a coagulative factor. It will be consumed and will be degraded. So its degradation and degradation product will be increased. It's logic. Now you don't have any excuse to forget it. It's not about memorization, it's about understanding the concept. Clear?
Clear.
And the management for the DIC will be management and supportive treatment for the cause. Let's have another nightmare for the surgeons. How many hypersensitivity you know? How many types?
4.
The very famous is 4, but Dr. Isha said 5, and I do agree with her. And the 5th type of hypersensitivity, do you know it, Dr. Isha? Graves. Thank you, Dr. Isha. Exactly. So it's a very tricky MCQ if it comes to you. Will be a surgeon making fun with his junior surgeon to ask him about the hypersensitivity type 5, it will be the Graves' disease. So in this question, he is asking you about the pathological process of a man who present with weight loss, fatigue, and lymphadenopathy and diagnosed with tuberculosis. What is this? It's a granuloma. And of course, it's not the very first time at the age of 23. And he has lost fatigue and lymphadenopathy. So sure, it's not the very first exposure. So this is what? This is a delayed one. And the delayed one will be type what? Which type?
4.
4, exactly. Thank you. So it's a delayed type, will be type 4, and the mediator will be which cell? T cell. T cell. The hypersensitivity is a tricky chapter. Do you agree? So the anaphylaxis, which is type of hypersensitivity? Type 1, that's great. How about the immune complex? Which type of hypersensitivity? Type 3, that's great.